شاء الله النهارده هقدم كيس برزنتيشن.
ايه اللي حصل؟
مش عارفه انا اتكهربت.
فين البحث؟ اكتشف المصدر يا علي.
ايوه خلاص اشتغل اهو.
خلاص.
انا will present a case redo case of atrial fibrillation، وهي مجرد هتبقى تطبيق الكلام اللي قاله الدكتور احمد ووفر عليا كلام كتير حقيقي.
علي في حاجه انت بتتحرك تحت.
انت بتتحرك بتفك حاجه.
ايوه البتاع الابيض الصغير ده بيقول لك اهو يفقد الوضوح.
خلاص هو هيشتغل.
خلاص هو اشتغل بس انت بتتحرك.
هي كيس لطيفه قوي احنا عملناها في شهر مايو اللي فات، وهي it's a redo case و our patient is مش عايز تشتغل. لا هي مش شغال بالاسهم دي. الاسهم بتشتغل؟ اوكي.
كده رجعت انت واحد.
Okay. Our patient is a 29-year-old male patient. He started to experience recurrent attacks of paroxysmal atrial fibrillation back in 2010, يعني 9 years ago, وكان عنده 20 سنة. He was so young to experience paroxysmal atrial fibrillation. All over the years, he received several antiarrhythmic drugs to maintain sinus rhythm in between the attacks. He received class 3, class 1C, he received digoxin. It partially controlled his attack, but 5 years later, after the first presentation, the episodes became very frequent and lasted longer. And his trips to the hospital for cardioversion became very frequent and very annoying to him. So by his primary physician, it was decided in يعمل PV isolation procedure using CAR2 system. That was done in 2015. عمل pulmonary vein isolation. And he remained in sinus rhythm for 6 months. بس بعد كده حصل له recurrence of atrial fibrillation, which was documented, and it was recurrent. And he was kept by his physician on antiarrhythmic drugs in the form of oral sotalol. وحقيقي the effect of sotalol كان very modest on maintaining his sinus rhythm and decreasing the frequency of the attacks. He stayed on antiarrhythmic drugs for 4 years, واعتقد في خلال 4 سنين دي he was discussing with his treating physician the prospects of doing another procedure. Most of the attacks اللي هي recurrent attacks of atrial fibrillation كانت بتجيله في خلال الفترة دي required hospitalization and pharmacological cardioversion, which was also not a very interesting thing for him. His echo كان almost normal left ventricular dimensions, ejection fraction 65%, وال left atrial dimensions were normal. This was his ECG of one of the documented arrhythmias. It's atrial fibrillation, recurrent atrial fibrillation documented on 12 lead surface ECG. So, based on the previously presented data of this patient, I have questions for the floor. What is your recommended treatment plan for this patient?
يا علي.
علي البتاع ده.
اصل هو البتاع اللي لامس في الارض.
أنا ما جيتش جنبه.
هو لامس والله.
So, إيه رأيك يا أحمد؟ What's your recommended plan for this patient? عيان من سن 20 سنة بيشتكي من recurrent paroxysmal attacks of atrial fibrillation، وقعد 5 years on antiarrhythmic drugs, and he actually done pulmonary vein isolation in 2015 بعد 6 شهور. We was kept actually for 4 years afterwards، يعني لغاية 2019 لغاية السنة دي was kept on antiarrhythmic on oral sotalol وما كانش ليه effect. What do you think? Was severely symptomatic.
I would get him to the lab once more based on the data that we presented. I would focus, of course we will check the veins, but see one of the most important things that I didn't mention is looking for non-pulmonary vein bleeders in this age group, namely SVT, ABNRT, ABRT, maybe something was missed.
Do an AP study you mean? ممكن طبعا. This is a very good plan. طيب, would you recommend for him to go or to keep on pharmacological therapy اللي واضح ان هو very effective, or even adopt a rate control strategy in this patient? I wouldn't. لا anti-arrhythmic drugs to maintain sinus rhythm ولا adopt rate control، مع ان في studies we have great، يعني عندنا literature كتير بيقول ان مفيش فرق بين ال rate control، بس ما it's not applicable. This patient is so young, the quality of life بتاعته هتبقى destroyed. I don't think ان هو is candidate for rate control strategy ولا حتى pharmacological therapy. So if your plan for redo atrial fibrillation procedure, when in your opinion is or was the most appropriate timing؟ يعني امتى اقول لا انا لازم ادخله اللاب دلوقتي؟ what are the criteria or justification.
بس سيمتوماتيك قوي لان الهارت ريت ايه في الهارت ريت بتاعه ما هوش عالي.
ما هوش عالي عشان هو ماشي على سكرين حضرتك، يعني هو ماشي على سكرين، فواضح ان هو لما بيجيله الاتاك اوكي هو ما بيمنعش الاتاك تيجي، بس ممكن يجيبها.
والسكرون في البريفنشن هل هو يعني ليه مش ماشي؟ ليه يعني السكرون بالذات؟
ما اعرفش، ده البريزنتيشن هو اللي اداله سكرين. It's not me. I don't know why they give him سكرين. هو في المرة الأولانية قعد 5 سنين he tried everything. Tried propofol, tried amiodarone, tried digoxin. Nothing worked for him. لا مش بيفرق. أعتقد إن هو كان بيتاخد in combination with something. ممكن with plus 1C أو حاجة. ممكن يكون كان واخده in combination with plus 1C or something. بس he tried several drugs وما كانش effective ده في المرة الأولانية أو في المرة الثانية. طيب. Timing of redo procedure usually depends on the extent of the symptoms. يعني it's not justified إن أنا أعمل redo procedure in a patient who might be symptomatic أو even asymptomatic. Timing of the procedure also depends على إمتى حصل الريكورنس زي ما قال دكتور أحمد في blanking period ولا after the blanking period. It seems in our patients إنه حصل بعد blanking period. تاني حاجة response to medical treatment، لأن في بعض recurrences أو بعض recurrent arrhythmias can respond بالذات لو هي can respond to anti-arrhythmic drugs اللي usually doesn't respond to anti-arrhythmic drugs اللي هي الماكرو-atrial tachycardia following ablation. دي عادة it has a very poor response to anti-arrhythmic drugs. I think our patient is fitting the criteria for a redo procedure. He's severely symptomatic, not responded to medical treatment with recurrence بتاعه حصل beyond the blanking period.
ليه هو واقف في الانتي-اريثميك بعد الابليشن؟ ليه هو واقف اساسا الانتي-اريثميك بعد الابليشن؟ ولا انت البروتوكول بتاعك بيستوب انتي-اريثميك بعد الابليشن؟
بعد البلانكينج بيريد بعد البلانكينج بيريد فهو وقفه.
ليه؟
الجايد لاينز هنكمله ليه؟ هو المفروض ان انا عملت سكسسفول بروسيجر بنجرب البلانكينج بيريد وبعد كده
معظم السكسس لسه ويز انتي-اريثميك drugs، يعني هاي ريت اوف سكسس.
ده لو حصل له ريكارنس.
معظم الريكارنس بيبقى نتيجه السكسس. معظم السكسس اللي بيعلى خلاص انتي-اريثميك drugs. انا اعتقد ان الانتي-اريثميك دي سكه ماشيه، وانا حتى بقول للعيال كده من الاول. بقول احنا مكملين، دي حاجه هتقلل وتوقفيها هيرجع.
وحصل له فعلا ريكارنس. So السلايد دي شفناها مع دكتور احمد قبل كده what is the electrophysiological problem يعني عادة في recurrence يعني الAFib recurrence what is usually the most common electrophysiological problem, and it was found in more than 90% of the cases with AFib recurrence is due to pulmonary vein reconnection. يا اما either due to distal isolation وده لازم we have to
عالي
انهي بتاع انا ما بجيش جنبها خالص.
بتاع البيضه دي هي
يمكن الكرسي هو اللي بيتبطيها.
ايوه انت اصلا شديدها على جاز البرسال
شكرا.
ما تلعبيش في الكرسي
مش عارفه الكرسي والله ما بجيش جنبه.
بس سيب النور ده. مين اللي عمل النور ده؟ شكرا يا ماما.
So in the majority of cases, even more than 90% of the cases, بيبقى recurrence is due to pulmonary vein reconnection. يا اما انا عملت الايزوليشن بتاعي غلط من الاول، انا عملت very distal isolation ف I didn't isolate the substrate, so I left a great part of the pulmonary vein substrate not isolated. فده انا لازم I have to go back and
How you visually assess the distance from the ostium to the
I don't do it by distance. You do it. أنا عادة لما ببتدي أشتغل I have to go to do the my fan for the left atrium. I mark, I tag the ostia of each vein. I tag it, and I don't go with distance. I go outside, just outside. لازم أبقى بره يعني. أنا شخصيا بحب أبقى بعيد أوي. بعيد أوي يعني. I go into the substrate as much as I can. There's no, مفيش reported distance you have to go. يعني انت مش ما اعتقدش ان مكتوب في الليتشر ان في انك في ماركت اوستيوم وتخرج مثلا كام ملي او تخرج كام سنتي، مش مكتوبه. You do it You do it just few millimeters outside the ostium. I see it a satisfactory distance from the ostium. You go outside and you do your ablation line, circumferential ablation line, to go around the antrum of both veins. في ناس بتشيت. Sometimes some people they cheat and they do a narrow circumferential ان هو you go just beyond the ostium. But this is not the ideal. You have to go way outside the ostium علشان تقدر to do a true circumferential ablation أو تعمل antral ablation. إنما اللي في ناس علشان to make sure إن their circumferential ablation is intact and they have no gaps in this, somehow they cheat. They just go outside the ostium ويقول لي أنا عملت كده antral ablation علشان الديستانس ما تبقاش كبيرة.
لازم يوصلوا لحاجة إنها إن هو يقول لي هي الحتة دي.
لغاية دلوقتي ما فيش. I think it's a personal preference. It differs from one operator to the other. حسب هو شايف الانتروم فين. بالظبط. You're abolishing the pulmonary vein triggers as well as انك بتعمل substrate modification. That's why success rate فيها اعلى عن segmental ablation اللي هو بيتارجت بس pulmonary vein triggers. تاني حاجة اللي هو أو إن حضرتك عملت antral ablation but there's gaps in your lines ودي most common mistake أو most common حاجة بتحصل. حتى sometimes if you do very good isolation, acute isolation, you are reported and there is pulmonary vein reconnection even if your ablation is intact and you did everything possible, there is a possibility of pulmonary vein reconnection afterwards سواء كان early or late. ثالث حاجه من اسباب الريكارنس اللي هي بتتسبب في الماكرو ري انترنت اتريال تاكيكارديا برضو ان يكون الانترو ابليشن بتاع حضرتك ان يكون فيه جابس ودي you have to resort to do activation and entrainment mapping زي ما قال دكتور احمد عشان to identify the circuit and apply linear lesions at the isthmuses. And the most common طبعا the majority of cases بيبقى فيه gaps في الانترال ablation او pulmonary vein reconnection. So what if the pulmonary veins turned out to be isolated زي ما قال دكتور احمد يا اما we go for non-pulmonary vein triggers يا اما بعمل modification of the arrhythmogenic substrate by linear ablations or do other ablations زي كافيه ablations ومفيش consensus او مفيش guidelines قوي تقول to go for one which protocol than the other. There is no guidelines for this. Back to our patient, our do procedure is justification بتاع redo procedure بتاعنا ان احنا we have a patient with symptomatic atrial fibrillation recurrence that occurred beyond the deep blanking period, which is drug refractory. In our procedure, we did before the procedure transesophageal echo to make sure that the appendage is free. All our procedures we do it under general anesthesia. Actually, a lot of studies have demonstrated انك لما تعمل atrial fibrillation ablation under general anesthesia بيبقى فيه lower incidence of recurrence مع as compared to conscious sedation عشان with general anesthesia you ensure انك بتعمل transmural lesion عن conscious sedation. conscious sedation ممكن العيان يتحرك ممكن البين يقوم العيان فوجدوا في study compared ما بين conscious sedation والgeneral anesthesia وجدوا general anesthesia recurrence فيه أقل. general anesthesia. We do general anesthesia.
بنشتغل مع عيال بتوع العشر وأسامة دياب الكونفنشنال بالكونشس ولا حتى بدون سيديشن.
برجلينا.
فكان طبعا كانت مأساة يعني. لكن لما أنا ورانيا مرة عملنا حاجة في دار فؤاد كونشس سيديشن إن التخدير ما رضيش يجي. العيان جاله اسبيريشن وانا طبعا نيمته بقى مورفي وبتاع وانا بقى عامله نفسي بفهم. اسبيريشن نموني قعد شهر في المستشفى شهر بيتعالج من اسبيريشن نموني من الكونشس سيديشن. لما جينا نشتغل في الدبرداش تاني كراي ابتدينا جنرال انستيزيا لقينا الفرينك نيرف ما بنقدرش نعمله ستيميليشن. فجه معانا شباب من الزماله عمر وادم والناس اللي هي واخده زي شهادات كده بتاعه التخدير قالوا لنا نعمل لكم كونشس سيديشن وعملوا لنا كونشس سيديشن للكرايو. فبقى الكرايو عندنا ما فيهوش جنرال شلناه. اما الكارتون خلاص مفيش ما نقدرش نشتغل من غير جنرال. لو التخدير غتته عليا زي ما غتوت كده هلغي الحاجه. جنرال انستيزيا.
جنرال بتيوب بكل حاجه.
جنرال انستيزيا
totally general anesthesia.
بمصر ريلاكسنت بكل حاجه. هي البروسيجر مش مستحمله ان العين يتحرك. لان هو لو جينا نديله دي الشوك واتحرك الماب بتتحرك الدنيا بتقلب من اول.
الافب ablation is a painful procedure. You cannot do it even under conscious. يا اما تعمل deep conscious sedation. You can do it with general anesthesia is better than the deep conscious sedation. In deep conscious sedation ممكن العيان يحصل aspiration. في نفس الوقت انت you protect yourself. انت you are saving the time of the procedure. You are saving the life of the patient. You're making sure انك بتعمل very durable transmural lesions. You're protecting your map ان ما يحصلش map shift. لان العيان حتى لو في conscious sedation ممكن يتحرك يبقى باظ لك الماب. You're doing your map from the beginning. فانت you're saving time.
دكتور رانيا كان في فرق في الابليشن دي في الستادي اللي باين فيها ايه؟ conscious sedation versus general anesthesia.
I don't remember إذا كان في فرق في الكومبليكيشن ريت ولا لا، بس أنا فاكرة إن كان في فرق في الريكورنس، بس أنا مش فاكرة إذا كان في فرق في الكومبليكيشن ريت ولا لا. أنا ما جيتش جنب الكرسي.
ما انا عارفه هو ده مشدود، هو المشكله ان هو ده مشدود.
أنا ما جيتش جنبه خالص.
ده موجود انا ده. خلي علي اقعد هنا، اول ما تلاقيه فصل هات لك كرسي اقعد هنا. لا ما تعملش حاجه. شديت الناس اللي حضروا خدت اساميهم.
وطبعا also through the procedure في continuous monitoring of activating clotting time. we keep the target بتاعنا ما بين 300 و 400 سكند.
الSCT بيبقى عندك موجود؟
الايه؟ ايوه احنا بيبقى عندنا الماشين وعندنا tubes و every 20 minutes we withdraw sample and we follow it. بنبتدي الاول ب 10,000 بندي 10,000 وطبعا الفلاشز اللي بتبقى على الشيسات كلها بيبقى عليها هيبرينايز صناين كلها بنتايتريت بقى الدوزز بتاعت الهيبرين based on the ECT. فالتارجت بتاعنا لازم يكون من 300 ل 400 سنه. البروسيجر بتبقى in this patient we try to do all the possible measures we can see to have durable transmural lesions. وطبعا لما يبقى عندك when you ensure durable transmural lesions or circumferential ablation lesions ده بتقلل الانسيدنس of AFib recurrence later on, and this is the second procedure. We did the procedure using 3D electroanatomical mapping اللي هو CART3 system, and we used the LASTONAV to do our map لان احنا كنا هنعمل voltage map. We used contact force ablation catheter, and this is the voltage map of our patient. We started the voltage map in sinus rhythm. As we all know, طبعا normal voltage in the left atrium is above the voltage of 0.5 millivolt, and it takes the color of violet. The color of violet like here, and the scar tissue, dense scar is the voltage less than 0.5 millivolt, and it takes the spectrum of other colors with dense scar بياخد the red color under the voltage أقل من 0.1 millivolt. And if we look here, this is our voltage map of the left atrium and the pulmonary vein. This is a PA view, posterior view. This is the right superior pulmonary vein, the right inferior pulmonary vein, left superior pulmonary vein, and left inferior pulmonary vein. Well, the idea of the voltage map is that you try to have an idea about the previous pulmonary vein isolation. لأن المفروض previous ablation will do a circumferential scar around the pulmonary veins. والpulmonary veins المفروض تبقى deep red لأن مش هيبقى فيها intracardiac recording أو pulmonary vein potentials. You will not record المفروض if you properly isolated, you will not record any electrograms within the pulmonary veins. But if we can see here, this is not the issue here. We see if we look posteriorly, posterior aspect of antrum of around the right pulmonary vein posteriorly, there is no isolation. It's almost normal voltage, and the posterior part of the right superior pulmonary vein shows normal voltage. برضو بالنسبة للleft pulmonary vein, the only part isolated is the lower part of the posterior aspect of the left antrum من تحت, إنما superiorly it's not isolated. If we look here into the anterior ridge اللي هو ما بين left atrial appendage and the left pulmonary vein, the ridge is not isolated. There's normal voltage there. Only there is distal isolation within the vein. Only والقراينة فيها برضو normal voltage. So it looks like we have pulmonary vein reconnection وعندنا great pulmonary vein reconnection both on the right side and the left side. بس if we look here posteriorly هنلاقي ان اللي هو circumferential الجزء بتاع ال circumferential ablation it extends into the posterior wall يعني السكار بتاع ال antral isolation extending into the posterior wall and there is a small scar in the posterior wall. فاحنا عندنا برضو there is a small scar or low voltage area in the posterior wall that we have to take care of. المفروض دي voltage map and this is our voltage map at the beginning of the study. طبعا the anterior ridge is not isolated, only the lower posterior part of the antrum of the left atrium is isolated. The lower part of the anterior antrum of the right veins برضو is isolated. The roof part زي ما قال دكتور أحمد is the difficult part برضو is not isolated. So we have a partial isolation on the right and left side. And we confirmed the pulmonary vein reconnection by putting the circular catheter or elasto catheter inside the veins علشان to record pulmonary vein potentials. هنا في in this photo, this is the elasto in the at the base of the right superior pulmonary vein near the antrum, the posterior aspect of the right antrum. الماوس هنا اللاستو مكانها اهو. هنا في recorded pulmonary vein potentials and when we moved it way inside the vein still we can record pulmonary vein potentials in the right superior pulmonary vein. And also on the left side on the anterior ridge ما بين left atrial appendage and the left pulmonary vein we put the mapping catheter ablation catheter at the upper part of the ridge and the lower part of the ridge and we can record pulmonary vein potentials at the mapping catheter. And when we did pacing we can conduct into the left atrium. So we made sure by the voltage map and by electrophysiologically برضو ان احنا عندنا pulmonary vein reconnection. So we've decided to do pulmonary vein isolation. واحنا طبعا ما عدناش ال pulmonary vein isolation, we did only ablation in the areas reconnected, mainly at the anterior ridge. We isolated the whole ridge and the superior part of the posterior antrum of the left posterior antrum. وهنا برضو right antrum posterior we isolated all of it up to the roof. And وبما ان احنا عندنا a small scar area in the posterior wall we've decided also to isolate the posterior wall of the left atrium. And we made sure ان احنا we have intact lines of posterior wall isolation, intact posterior wall isolation. And we had some measures. طبعا كان measures اللي احنا استخدمناها to enhance durability of the pulmonary vein isolation, general anesthesia, delivery of contiguous transmural lesions as much as possible. We used contact force, والminimum contact force اللي كنا بنستخدمها كانت 10 grams. Rigorous testing for both exit and entrance block including pacing at circumferential ablation line, post ablation waiting period عادة بنستنى 20 minutes. في other measures بس دي اللي احنا ما استخدمناش. We don't have a steerable sheath. We don't use the multi-pore irrigated tip catheter. طبعا ما عندناش adenosine. And this is the intracardiac recording from the pulmonary veins before and after isolation for right superior pulmonary vein. دي elasto for right superior pulmonary vein showing pulmonary vein potential. ده before complete isolation of the pulmonary vein. وبعد كده disappearing of the pulmonary vein potential with entrance block after ablation. وده pacing from the elasto. Showing exit block after ablation. There is no conduction into the atrium. The patient, the redo procedure was performed last May, where the patient is arrhythmia free since then. A 24-hour Holter recording is planned at the end of the planking period. كده الكيس خلصت. التيك هوم مسج بتاعتنا ان ال recurrence of atrial fibrillation usually occurs in it's very common. It occurs in 30% of the cases. وعادة require redo cases in 20 to 40% of the cases. And the majority of the cases of AFib recurrence بتبقى due to pulmonary vein reconnection. The most recent consensus statement on catheter ablation of AF suggests the first step in احنا نعمل repeat pulmonary vein isolation to make sure that the pulmonary vein is isolated. And procedures to check each pulmonary vein for electrical reconnection followed by re-isolation of pulmonary veins as necessary as there is data showing reasonably good outcomes with repeat pulmonary vein isolation alone. Thank you.